Hey everyone, I'm Jeremy Seitz, a Pediatric Critical Care Fellow at UNC Children's. Welcome to the first of 4 video lectures on congenital heart disease for pediatric residents and medical students rotating in the PICU. The goal of these talks are to highlight the important presenting signs and symptoms, initial workup, and basic stabilization strategies that you will need to know for the American Board of Pediatrics licensing exam and as a general pediatrician or frontline pediatrician in urgent care centers and emergency departments. We give these lectures in person every Friday morning on the unit, but for those of you on call or taken away from the lesson by clinical duties, I wanted you to have access to these lessons from home. So let's get started with the talk from week 1. Let's start with a common clinical vignette that you're likely to come across at some point in your career as a general pediatrician. This case involves a 3-month-old male, previously healthy, who is admitted to your Gen Peds inpatient service for further workup following a cyanotic spell at home. The parents report to you that he was feeding from the bottle when he developed respiratory distress and a blue-gray skin discoloration of the face and trunk. The spell had resolved upon arrival to the emergency department, but an oxygen saturation of 85% was present despite the infant being calm and comfortable. The remainder of his vitals were within normal limits. Your team has ordered an echo. I want you to think about the next 4 questions. Feel free to pause the video and write down some answers, and then I'll jump into my answers. Question number 1, what is your leading diagnosis? Question number 2, what might you expect to find on physical exam? Number 3, what findings would you expect to see on the echo? And number 4, what findings would you expect to see on a chest x-ray and EKG? So number 1, I think we have to be very suspicious here of a cyanotic congenital heart lesion, primarily because of his SAT of 85%, despite being calm and comfortable. That really has to raise a red flag to you that this is a heart condition. So let's recall our 5 T's that we learn in medical school and intern year. An easy memory device to remember these by is counting to 5. So number 1 would be truncus arteriosus, or a single trunk, one trunk. 2 would be transposition of the great arteries, 2 great arteries. This is actually the most common cyanotic congenital heart lesion. Number 3, tricuspid atresia, tri. Number 4, tetralogy of Fallot, or tetra meaning 4. And then finally, number 5, TAPVR, which includes 5 letters, total anomalous pulmonary venous return, or TAPVR. So we're concerned for cyanotic congenital heart lesion. Transposition of the great vessels is the most common, but remember that generally presents within the first few hours of life, if not immediately after delivery. Number 2 is tetralogy of Fallot. That can present in the neonatal period, but it can also be a more indolent heart lesion that shows up, a few weeks or months after birth, the reason for which we'll talk about in the next couple of slides. So I think in terms of the patient's age, the fact that his SATs are 85% and this spell has been sort of, episodic, marked by hypercyanosis, you really have to be concerned for a TET spell related to tetralogy of Fallot. Number 2, what might you expect to find on physical exam? You'll likely find that the child has a really pronounced, harsh murmur, likely to be heard, throughout the precordium, but primarily over the sternal border. Number 3, what findings would you expect to see on the echo? But here I'm just asking what are the features of tetralogy of Fallot. Number 1 would be a large unrestricted VSD. Number 2 would be RV outflow tract obstruction and pulmonic stenosis. Number 3 would be right ventricular hypertrophy related to the RV outflow tract obstruction. And then number 4 would be an overriding aorta. We'll talk about this a little bit in the next slide. And then finally, what findings would you expect to see on a chest x-ray and EKG? Recall the classic chest x-ray finding in tetralogy as the boot-shaped heart. That'll be something that you're likely to come across on your board, so I want you to remember that, and we'll see an example here in a couple of slides. You may also see a paucity of lung markings or a very black, very dark uh, lung fields on that chest X-ray. And then EKG findings, you can expect to see pretty universally. You can expect to find right axis deviation, uh, RV hypertrophy, and then you may also see signs of right atrial enlargement, which uh, involves increased P wave amplitude and leads to 3 in AVF. So we are suspecting tetralogy of Fallot here, and indeed that is what your echo will go on to reveal to you. So we talked about the 4 features of tetralogy of Fallot, but really if you think about it from an embryologic point of view, it can really just be boiled down to one anomaly or abnormality, and that's anterior malalignment of the conal septum. Open Pediatrics has a really wonderful review of this. If you just go to YouTube and type in Open Pediatrics Tetralogy of Fallot, you'll see a 20-minute lecture from one of the cardiologists at Boston Children's. It's a wonderful review of this, so I would recommend it highly if you want to learn more. But you can really just remember tetralogy as that single deficit that leads to everything else. So depending on the severity of the malalignment of that conal septum just meaning a portion of the ventricular septum. Depending on the severity of that malalignment, you may see one of 3 different types of presentations, which we'll talk about in a couple of slides from now. But really all the features boil down to that. So take a look at the picture here. You have a normal heart in diagram A, and then an abnormal heart consistent with tetralogy of Fallot in picture B. It all boils down, once again, take-home point here, to anterior malalignment of the conal septum. That gives you the pulmonic stenosis, or RV, outflow tract obstruction, which ultimately leads to RV hypertrophy. That gives you, of course, the VSD, and then also leads to the overriding aorta that's textbook for TOF. All right, so here we have examples of a chest X-ray and an EKG, of which we talked about a couple of slides ago. Notice the cardiac silhouette here. It has that classic boot shape. And again, I want to really hit this one home. You're likely to see this on your board, so to try to recall the boot-shaped heart in Tetralogy of Fallot association. I told you can see a paucity of long interstitial markings. I wouldn't say that's the case for this chest X-ray here. So it's certainly not a necessary finding, but it may be something that you'll see on chest X-ray, particularly in those children with severe pulmonic stenosis or pulmonary atresia due to that really restricted or absent pulmonary blood flow. And then to the right here, you see an EKG demonstrating RV hypertrophy, right axis deviation, and then looking at leads 2, 3 in AVF here, I think some slight enlargement of that P wave amplitude, reflective of right atrial enlargement, like we talked about. Now I want us to talk about tetralogy of Fallot as a spectrum of disease processes. It's not a one-size-fits-all congenital heart lesion. There is a spectrum of mild, moderate, severe. Again, going back to slide 2, based on the severity of the anterior malalignment of the conal septum, that dictates which end of the spectrum that you fall on. I think this slide is really important for the general pediatrician because you may be the one diagnosing the neonate or infant with tetralogy of Fallot. You may be the first one to pick this up. Most babies are going to have this diagnosis made in utero, but there will be that subset of patients whose mothers have really poor access to resources, who have had inadequate prenatal care, or went to all of their appointments, had their anatomy scanned, and this was still missed. These do happen. So you may be diagnosing this, and I want you to think again of tetralogy of Fallot as a spectrum. Whatever end of the spectrum they fall on, that will dictate the clinical signs and symptoms that you see. So let's talk about mild first. This would be mild anterior malalignment of the conal septum, leading to mild pulmonary stenosis and RV outflow tract obstruction. This will be the baby that is pink. They'll have adequate pulmonary blood flow, and indeed at 4 to 6 months of life will start to behave as a child with a very large unrestricted VSD would and heart failure type physiology. So this would be the patient that would present with adequate saturations, but with heart failure type symptoms, including pulmonary vascular congestion, dyspnea, difficulty feeding, difficulty growing, perhaps enlarged liver. The moderate type of tetralogy of Fallot is that textbook type of patient, like we talked about with our 3-month-old in slide 1. This would be the patient that is oftentimes pink at birth. They have a somewhat moderate degree of pulmonary stenosis and RV outflow tract obstruction, but at birth adequate pulmonary blood flow and normal O2 saturations. However, as time goes on, the RV muscle bundle becomes more and more hypertrophied with time due to this pulmonary stenosis. And with time, they'll start to develop these classic tetralogy of Fallot spells like our 3-month-old demonstrated. And with time, they'll chronically have insufficient pulmonary blood flow that will lead to lower than normal O2 saturations. The severe type tetralogy of Fallot patient will present within the first couple of days, typically, of birth, because they have very insufficient or even absent pulmonary blood flow due to severe pulmonary stenosis or even pulmonary atresia. These children will be PDA dependent because they have such severe insufficient pulmonary blood flow. So they'll oftentimes present when their PDA closes. It's your task as the general pediatrician to pick up on this, that they have insufficient pulmonary blood flow related to a congenital heart lesion, and start them on Prostin, and then call your cardiologist and intensive care doc and get them admitted for further workup and management. They'll need that pulmonary blood flow either from the ductus, which you help provide by starting them on Prostin, and then within the first couple weeks of life, they may go for a PDA stent, or if their PDA is not adequate or is already closed, they may need some sort of extracardiac shunt, like a BT shunt, which is a subclavian artery to pulmonary artery shunt that in a sense acts like a PDA, but is placed surgically by a cardiothoracic surgeon. It's really important for you as a general pediatrician or frontline pediatrician in the urgent care center or emergency department to be able to recognize the tetralogy of Fallot spell and start initiating these initial management steps to help resolve the TET spell and provide that sufficient pulmonary blood flow. So remember these 6 steps. It's easy to remember if you think about what you're providing physiologically to the patient. The first thing that you'll do is knead a chest, and this may even be something that parents recognize that works for the baby. They may be changing their baby's diaper, for instance. The baby becomes very fussy during this, and the parents find that when they raise the knees closer to the chest in the act of changing the diaper, that the episode gets really, really less profound or even resolves. The way this works is increasing systemic vascular resistance. So you're in effect changing that right to left blood flow caused by severe RV hypertrophy to left to right blood flow and allowing blood to shift across that VSD through the pulmonary valve and on into the lungs to provide sufficient pulmonary blood flow. The second thing that you need to think to do is provide them supplemental O2 via nasal cannula. Remember that oxygen is a very potent pulmonary vasodilator, and so it'll relax the pulmonary artery and hopefully help have more antegrade flow across the pulmonary valve. The next thing that I want you to think of doing is providing a fluid bolus. These patients have very stiff, non-compliant right ventricles, and the way to overcome that is simply to fill the tank up. The more preload that you can give that right ventricle, the better it will be at pumping blood across this, stenotic pulmonary valve or stiff RV outflow tract. So simple management step, but important to remember. The next thing that you will think of doing will be some sort of medical therapy, so morphine or propranolol. Propranolol probably in conjunction with your cardiologist's recommendation. But definitely as a general pediatrician, if you haven't spoken to your cardiologist yet, you're waiting on them to call you back. Morphine at a low dose of 0.05 mg per kg should help globally relax the patient, but by a mechanism we're not quite sure of, it can also relax that RV muscle bundle that becomes dynamically more hypertrophied during these tetralogies of Fallot spells. And then finally, think about phenylephrine. This may be more of like a board question or something for you to remember to ask your ICU colleagues or cardiologists while you have them on the phone and stabilizing the patient. Probably wouldn't do this without the direction of an ICU doc or cardiologist. But remember, phenylephrine is alpha specific, and so in that vein, it will stimulate the alpha 1 receptors and cause vasoconstriction. And just like in knee to chest, the act of increasing that SVR will help left to right flow and hopefully help provide you adequate pulmonary circulation. All right, so I wanted to finish out our talk on tetralogy of Fallot with a short discussion on the repair. Initially, I left this piece of the discussion out when I first started giving this talk to residents and medical students. But I was finding that a lot of them were asking me about this at the end of my talk, so I decided to put it in. It is probably beyond the scope of the need-to-know level of information for a general pediatrician, but it's interesting, and so I wanted to just talk about it for a moment. If you'd like to see a really nice animated example of this surgery, I encourage you to click the link here or just type in on YouTube Cincinnati Children's Tetralogy of Fallot Repair. It's a really nice 2 or 3 minute video that breaks it down. But essentially, when you think about CT surgeries for congenital heart disease lesions, it falls into one of two categories, and that would be palliative or complete repair. A palliative surgery provides a new type of physiology to the patient, a new type of long-term physiology to the patient that isn't per se a normal physiology, but will allow the patient to live with their congenital heart lesion. An example of this, of course, would be hypoplastic left heart and the 3 palliative surgeries that they undergo to eventually have Fontan physiology. And we'll talk a little bit about this in a couple of weeks. And then category number 2, complete repairs, seek to provide normal anatomy and therefore restore normal physiology to the patient. And so tetralogy of Fallot would be an example of that type of repair. Essentially, your goal here, the surgeon's goal here, is to reverse the defects in TOF. And so that generally includes closing the VSD in such a way that the aorta arises from the left ventricle and not the right ventricle. And then the next goal would be reconstructing that RV outflow tract that for these patients has been very restrictive in terms of their pulmonary blood flow, reconstructing it in such a way that they have now sufficient pulmonary blood flow. In doing this, to some degree, you'll injure that pulmonary valve, perhaps even obliterating the pulmonary valve. And so an important question for us as ICU docs to ask our surgeons when these patients come back from the operating room after their repair is whether or not this was a valve-sparing surgery. But again, just in simple terms, think of the repair as reversing these 4 defects present in TOF. All right, so I think that's all for this week. Please feel free to reach out to me via email or find me on the unit if you have any questions or clarifications regarding the talk. Certainly, if you heard anything that you disagree with or you've heard conflicting information, I'd like that feedback. So feel free to find me and let me know. If you want any links, resources, textbook readings, anything like that, I'm happy to share that with you as well. So feel free to reach out. I'll see you guys at the simulation scenario, and feel free to tune in to the next audio recording next week. Thanks.